Another question that really comes up a lot with patients, and a question that was asked during your talk, is if radiation increases toxicities for patients that are on targeted therapy, and what do we know about the safety of combining the two?
I think, I mean, all of these studies that have been completed or, moving forward in the right direction, have asked that question very critically because, as we know, some of the TKIs can increase the risk of pneumonitis, and then you add that radiation to that. But the safety profiles so far have been pretty positive in the sense that there hasn't been some overwhelming signal that would make us very concerned about using them together. I still hold the TKIs a few days before the SBRT till a few days after, an abundance of caution. Remember, the lesions that we're treating with SBRT are relatively small lesions. We should be able to protect the rest of your lungs. So far, I think the signals are positive about being able to use both together without significant toxicity.
Yeah, I would agree with that too. We at Emory, we presented our experience of osimertinib with SBRT to mainly lung and bone lesions a couple years ago at World Lung, and we had pretty low toxicities. So I definitely agree with you on that point. I generally, when I'm seeing these patients, will call the medical oncologist and we'll have a discussion about whether or not the medical oncologist is comfortable with the hold on the TKI. And many times, the medical oncologists I work with are not comfortable with stopping the TKI for radiation. So, more often than not, I am treating patients with the TKI on board. But I think the important thing from the patient point of view is to make sure that your doctors are communicating and that there's a plan for what you're going to do with the drug therapy while you're getting radiation, and everybody's on board and is in agreement with what's happening. Because sometimes, particularly if you are getting radiation at a different facility from where your medical oncologist is, the communication may not always be happening. And I think that it's just an important point as a patient that you can advocate for yourself and just make sure that your doctors are talking to each other and are on the same page when it comes to how you're taking your targeted therapy and if you're holding it during radiation. Do we have any comments on that from our medical oncologists on the panel?
I really agree with the points that have been made by both of you, Dr. Iyengar and Dr. Higgins. Unfortunately, there's no one universal approach that we take in terms of the overlap between the TKI and the radiation. In Boston, generally, our practice brief, where you don't have to worry as much about the flare of disease with the holding of the TKI. The discussion becomes much harder when the radiation has to be of a prolonged course, right? If someone's requiring 3 weeks or longer of a radiation course, then there really has to be a careful weighing of how much active disease burden is there at the present time, and then what area is being irradiated in terms of potential overlapping toxicities. Certainly with certain TKIs, for example, with osimertinib, where we know that there's a pretty significant risk of pneumonitis. If there's anywhere in proximity to the lung that's being irradiated, we will definitely not overlap. Similarly with bowels, if we're worrying about diarrhea and bowel toxicities, then we will not overlap. And then with the brain, we're very careful as well. With a lot of the CNS penetrant TKIs, we worry about increased risk of radionecrosis. And so we generally try to overlap, overlap the Dr. Royce, Dr. Desai, do you have any thoughts?
Yeah, I would agree with that approach. I mean, I think, the last thing you also want to do is get in a scenario where then you do have a significant toxicity, and then you might have to hold therapy even longer because you ran into a toxicity, rather than knowing that by and large, if you restart this therapy, you should be able to get the response back. And, I don't think there's any data to suggest that holding the therapy will lead to increased risk of resistance or anything like that. So I think it's always better to err on the side of safety, especially when you really want to engender a long-term response with less toxicity.
Yeah, I completely agree. And I think I agree. My practice is sort of consistent with what Dr. Iyengar pointed out in terms of sort of peri-radiotherapy period, discontinuation or holding of TKI. I think that's, again, out of abundance of caution.
And I will also mention one of the things we can do from the radiation point of view is we can alter the schedule to try to make the amount of time where the TKI is held as short as possible. So that's another thing that you can sort of ask your radiation oncologist if that's possible, just to, instead of giving SBRT every other day, can you give it every day, for example? And that's a way that we can, I think, optimize our outcomes potentially.